We take care of children. We like taking care of children. And everybody, I think, has a nuance of what they do and don't like taking care of, or do and don't actually take care of. But the message really is that in most places, there are some adults and some children, and it's important to understand the differences and the similarities with regard to children and adults. And we don't have the government chasing us down yet. However, I can assure you that pediatric care also gets heavily scrutinized, and more, you know, they start with giving you a carrot and, you know, applauding you for doing extra, and that becomes standard, and then they start penalizing organizations for not doing what is now considered standard of care. And it's very much in the forefront in adults, but we're aware that it also is coming in pediatrics. So it behooves us to have elements of standardization in our processes as well. So I'm Maeve Sheehan, I'm an ICU physician. I work at Children's, and Cam is an ED nurse who works at Cook Children's. So there's good representation of pediatrics here today. And we were involved in this collaborative. So our objectives are to discuss the impact of pediatric sepsis and to outline the process of care throughout the hospital continuum, like we've talked about: triage, assessment, treatment, transfer escalation, reassessment, de-escalation. And then we're going to briefly talk about some of the national collaboratives, and both regional and national collaboratives. So there's a tremendous amount of work going on at the moment in pediatric sepsis, both at a national level with CHA, which is Children's Hospital Association of America, CHAT, which is Children's Hospital Association of Texas, and then DFW Hospital Council. So there is a lot of work going on. And why is there a lot of work going on? Similar what that's been presented before. This is data, I might add, from 2002. Almost nothing has changed. So in the last 15 years, despite knowing what we know and despite doing what we do and knowing what we should be doing, we have really made no difference in pediatric mortality and outcomes from sepsis. There was a tremendous, when antibiotics were discovered and were used, and the notion of giving fluid boluses was understood, pediatric mortality prior to broad use of antibiotics and broad use of fluids, mortality was 97% in children. By 2002, the mortality was 10%. The mortality is still 10%. And you may say, well, that's not much, it's 30% in adults, but it's many thousands of cases per year. It's many thousands of deaths. It's 7% at least of all deaths in children. And children have a huge lifespan ahead of them, and we're killing them at 1 year of age. And there are millions of hospital days and billions in dollars of cost. That's entirely preventable. There's a developmental aspect to sepsis that is one of the reasons why we're here talking about sepsis in children. So, you know, you always hear children are not small adults. Well, in the case of sepsis, that is true. So cardiac failure is a predominant cause of death in children, whereas in adults it's predominantly vascular failure. And what do we mean by that? Essentially, the infant myocardium is very sensitive to calcium, to septic mediators, etc. So the management of sepsis in children is slightly different. The fundamentals are exactly the same. So if you take anything away from this conversation, from all of us today, it's you need to intervene early, rapidly, you need to give fluid, and you need to give antibiotics. And that's sort of the fundamental tenet. The rest of it is sort of down the line. But if you don't recognize somebody's septic, give them fluid, give them antibiotics, you are so far behind that you may never catch up, and the result is death. And the beauty of taking care of a child with sepsis is it's completely recoverable. I work in the ICU. There's almost nothing that comes into the ICU that you see that you have a normal child that gets back to a normal child. Well, somebody with septic shock is completely treatable and recoverable, and gets back to normal if you are on top of it and intervene early. So as I say, for children, cardiac failure is a predominant cause of death, so you need aggressive fluid resuscitation, inotropes, vasodilators, nitric, and ECMO. ECMO is more common now in adults than it used to be. It's not unusual for us to give 100 per kilo of fluid, which you would never give probably to an adult, or 200 per kilo of fluid. We give tremendous amount of fluid to children. There's an age distribution of severe sepsis in children. Small children under a year of age are much more likely to die, and then older kids towards the teenage years. So there's a difference in who's likely to die. And I think the younger kids, it's harder to detect. We talked, and you hear over and over again about goal-directed care. So to impact the outcome from shock, intervention needs to begin early. And the key point from this is the mortality risk doubles for every hour of uncorrected shock. So you wait an hour, they're twice as likely to die. And early, rapid fluid resuscitation pediatric septic shock is associated with improved outcome. So in this slide, you can see the difference between giving less than 20 per kilo. So that's highly fluid sensitive. So mortality in this, and this is a pediatric study, mortality was 73% when they gave less than 20 per kilo of fluid. It was 52% if they gave up to 40, and was 33% if they gave more than 40 per kilo of fluid. So it's early fluid and large volumes. Now, I'm not saying you give 100 per kilo of fluid straight off the bat. You give, in pediatrics, we start usually with 20, assess, and 20 per kilo, 20 per kilo, 20 per kilo, and you assess in between. But you give it, and you're not afraid of fluid. Our standard is usually to give 60 per kilo in an hour or more. Time sensitive, again, if you delay, they die. So here they looked at 30 minutes, 60 minutes, and more than 60 minutes and the likelihood of death. So rapid fluid resuscitation and aggressive fluid resuscitation is key. Timely administration of antibiotics. Now, this is pediatric study. Delays in antibiotic administration as short as 2 to 4 hours were associated with adverse outcomes. This one is an adult study. Initiation of inappropriate antimicrobial therapy results in a 5-fold reduction in survival. So early antibiotics, appropriate antibiotics. That's why it was already mentioned, broad spectrum antibiotics are important. Again, the longer you wait, the more likely you are to die. So again, other nuances to goal-directed therapy in children. We advocate for early hemodynamic monitoring, use of inotropes, vasopressors, checking glucose, calcium, thyroid hormone. Hydrocortisone remains controversial, but we at least check cortisol levels, and then there's other therapies which are specific to pediatrics. We have clinical pathways. We have had clinical pathways for a number of years, but it's not enough to have the information. You actually have to do the work. So many places. This one is Peds Critical Care Medicine, Boston, Dallas. So we all have pathways. What we need to do is actually use them. So what are the problems 15 years later? Still, we fail to recognize the problem. We fail to implement care in a timely manner, and mortality has not changed in 15 years, even though we know what we should be doing. And it's not difficult. It's not like we have to spend millions of dollars and have some weird process in place. It's fluid and antibiotics, and inotropes if they're really sick. So what is new? So why are we here today? Why are we talking? I think the new focus is on we're working together to improve outcomes. So again, Cam is going to talk about the process and the specific process which relates to early recognition and timely intervention. The plan is to reduce mortality. So the CHA initiative, the plan is to reduce mortality by 75% and reduce morbidity from sepsis. And we are all collaborating. We're here today. It was part of this DFW Hospital Council collaboration, and we're involved in both regional and national collaboratives. And Cam is going to take over and talk about the specifics of triage assessment, etc.
I'm going to rock and roll through this stuff, but the number one thing I want you to take home with is pediatric patients do not suddenly deteriorate. Healthcare professionals suddenly notice. That's the big difference, especially with kids, because Joni's patients, she can say, so, do you have a source of infection? And my baby goes, blah, blah, blah. Yeah, they don't talk. So what we have to do is we have to recognize. So what we're going to talk about just real briefly is a model of sepsis. I am not exactly a nursing model person. I work at the bedside and I enjoy working at the bedside. However, you need, whatever it is, an organized approach. This is one that has been studied, that's used quite a bit, and it is an organized approach. How do I recognize a pediatric patient at risk for sepsis? Number one, predisposition. That's the P of pyro. Is there something that makes this kid at risk? They're less than 60 days. We know that neonates have issues. They have a congenital heart defect. Those kids are at a higher risk for endocarditis. They've got indwelling, they've got central lines, they've got sickle cell disease. They're at higher risk for some of the other infections. If there's something there, they just got sent home a week ago with the severe pneumonia. If there's something that puts them at predisposition, there you go. For us, we put it in our sepsis tool, as Joni was talking about, and that's a couple of points. Do they have something that says, ooh, I've got an infection? Do they have fever? Do they have, are they cold? I worry about those a lot more, to be perfectly honest. And of course, in our pediatric patients, so mom, does he have fever? They put like this. Yes, he does. Okay, I'm going to check it. So in the pediatric patient, fever is diagnosed from 1868. I'm writing an article on this. 1868, we decided fever was 100.4. It hasn't really changed since then. So is there subjective or is there objective fever? Is there a draining area of the skin? Oh my goodness, abscesses are crazy these days. Got this big old red angry thing. That puts that kid, that makes you think, ooh, there may be an infection going on for those kids. They get points as well. Response to infection. Now this is a big one that's pediatric, very pediatric, is our precious little hearts, we got lovely big fist size. Our little rascals have walnut size. So they can't increase their stroke volume, they increase the rate. So tachycardia and tachypnea are early signs of distress in pediatric patients. Now, this is not just, oh, their heart rate's 120. This is big old changes. So like for us, and we've changed this one quite a bit. A 2 month to less than 1 year old, their heart rate's greater than 180 and their respiratory rate is greater than 40 before they trigger. So it's some pretty big significant changes that make you say, this is the kid that I am really, really worried about. Then here's the big one, as Joni was starting with. Then now, are the organs affected? Once the organs start being affected, those are the kids that really, really make you go over into the severe sepsis, maybe even the septic shock. Because the biggest difference in the pediatric patients for septic shock is hypotension. And this is not, again, just a little bit of a change. This is a pretty big change. The fun part with pediatric patients is all of this is age specific. So you're going to want to, and there's guidelines out there. PALS is happy to share their guidelines with you, and then you figure out, we're happy to share our guidelines, but these are pretty big differences that make you realize that something in those organs is not working as advertised. So we recognize the kid. We also go with the Surviving Sepsis campaign. The Society of Critical Care Medicine says, great guidelines. The last ones were 2012, so I'm going to assume they'll be coming out with some new ones very soon. But for pediatric patients, number one, recognize. Number two, initiate vascular access. Number three, aggressive fluid therapy. And number four, antibiotics. It's kind of easy. It really is cookbook medicine, just so we do it right. So, but of course, we are in medicine and we are in pediatrics, so we have to make it look a lot more exciting than it is. So here we are. Now we have all sorts of things. We have timelines. I love, they call it 3-hour bundles. Yeah, if you wait 3 hours, as we've already talked about and Dr. Sheehan said, then we have a huge increase in mortality and morbidity. So we're taking minutes instead, just to make it more exciting. Number one, early recognition. They give you 5 minutes for that. I think that's very nice. So we've recognized, we've got in 5 minutes, aggressive fluid resuscitation. Some of the beautiful studies say that our first bolus should be in a minimum of 30 minutes from recognition. Time zero, triage time, recognition. We should have at least our first bolus in. We should have already started reassessing and getting ready for more. As Dr. Sheehan said, it would be nice to have all of 3 boluses in within the first hour. Now, we'll talk a little bit in just a sec about what the recognition is, and that's going down our adjuncts. These guys need to be on full monitors. Remember that sepsis is a cellular response. It is not, something in your blood. It is in the cells. So we're having to recognize from the cells and what the body is responding. So full monitors. Consider oxygen, especially if they have a funky blood gas, because I'm wanting to get the oxygen to the cells. I'm also doing lab studies, just like with Joni's, we're really heavy into lactates as well, yay. CBC, lights, cultures, lactate, a blood gas if you're looking at your base access. And then we're gonna repeat those serially if they're abnormal, and that's what the guidelines say. If the lactate is abnormal, you repeat it until it's normal, because that's showing how your resuscitation is going. So putting it all together, reassessment, transferring, making it pretty, and this is kind of throwing our sepsis protocol in here. The bottom line is reassessment. I give a fluid bolus, I reassess. Did their heart rate go down? Are their respirations better? Do they look better? Is their skin color, temperature? How's their cap refill? How's their blood pressure? Look at it. What's their lactate? If it's greater than 4, we're needing more. Let's keep it on going. We're reassessing constantly. How's that kid looking? When we get up to about 60 milliliters, there's one of the definitions, because I love definitions, is responders and non-responders. Non-responders, I've given 60 mils per kilo, they are still not looking better. They're still tachycardic, they're still tachypnic, they're still hypotensive, their lactate is still high. Those kids are at a pretty big risk. Those are the ones that Dr. Sheehan's going to be taking care of in a very short period of time. So what we need to do and think about these guys is, number one, those are our scary ones. Those are the ones that we'll start thinking about pressors. We can think about it earlier than that, absolutely, but those are the folks that are going to need to go farther down our little algorithm of care. Vasopressors for hypotension, these guys need ICU. Some of the other kids who responded great, they look good, we're waiting for the cultures to come back, or we know they're needing a couple of days of antibiotics. Some of those kids that are not probably the septic shock, those kids could go to the floor. We just kind of have, depending on what our secondary screen looks like, but all of them need serial assessments, and they need beautiful communication. It's so funny how we really, while we have all talked together over the last few months, communication is the most important thing we can do as healthcare professionals. This is what they saw, this is why our sepsis score was, this is why we thought they were septic, this is what we have done, these were the changes, whether they worked or not. That way the next person who takes care of these kids can see those little subtle changes, not just the great big changes.
Take care of children predominantly, but we also get adults into our facility. Other facilities may take care of adults predominantly, but they also get children. So it's important that we all collaborate, we learn from each other, we share what knowledge, we share what works well. And the fundamental knowledge doesn't change. What helps though is to understand how people get around some of these processes. What do you use as sort of your trigger tool? What do you use when you run into this roadblock? So collaborating and sharing information is key. And as I say, that's why we're involved in these national initiatives. So we have national initiatives now that are looking, and it's similar to the adult processes of we have aims, we have key drivers and bundles and secondary drivers. And this is both at a national level, at a Texas level, and then at a local level.